I'm now absolutely delighted to welcome Dr. Tom Dawson from McKesson IOG. I think, Tom, I'm really sorry. We usually have a room full, but I think it's kind of lunchtime and things. But anyway, Tom is particularly interested in the sort of the homeless aspects, and that's quite interesting in terms of home care. But I'd like to hand over to you now and welcome you. Thank you.
Thank you very much. So good afternoon, everyone. It is afternoon now, and I thought we might be a bit light on the ground as I'm talking about something outside the home, and I'm also talking about it on lunchtime of the last day. So I'm going to be talking about Lincus, which is a tool that was developed to assess the impact of interventions on the homeless population in the Liverpool City Council region. First of all, I'll tell you a little bit about myself, a little bit about Rescon and what we do, which is actually a lot of the other stuff is actually based within the home care. I'll then talk about the My Liverpool collaboration, which is a Dallas-funded project, and then I'll get on to talking about the meat of the topic, and I'll try and be in good time so there's time for questions as well. So Rescon is a company that was founded in 2011, and it was really founded out of frustration with middle management, out of frustration with universities not working together, companies not working together, so it was developed as a collaborative vehicle. It was set with three principles in mind. One was to solve real-world problems. The other was to work in collaboration. And the third was sustainability, ranging from sustainability to Rescon, through to sustainability of partners, to sustainability of customers and end users. So what we do is we do a lot of work with sensors. So a lot of this work's been sponsored by the US military. So looking at the health and performance of warfighters, which we are transitioning into the health and performance of people in their home. So we're trying to get away from the disease model to looking at the performance model. So it doesn't matter if you're at end of life, performance still matters to you. So you want to have something that will make you feel better. That's really what we consider the so what. We also work on analytics, so which is really where a lot of the work with Lincus stemmed from. So we look at analysis of physiological signals, we look at analysis of user input, analysis of surveys. We tie this in with geolocation, with weather, with barometric pressure, with news reports. So there's multiple different aspects of this. I now want to talk about the more independent, or the My collaboration, which is funded by the Technology Strategy Board under a program called Delivering Assisted Living Lifestyles at Scale. So they needed to have something big, and it needed to rhyme with be an acronym that spoke with Dallas, so I think that's how that came out. I'm part of that project up in Liverpool, and I spend a lot of my time in Liverpool, though I am based actually in Farnborough. So with the Dallas program came out of a whole system demonstrator, part of the assisted living project 1 and 2, which was run by the Technology Strategy Board. With that, they showed that telehealth showed a 15% reduction in A&E visits, 20% reduction in emergency admissions, 14% reduction in elective admissions, and a reduction in bed days and also tariff costs, and overall a 45% reduction in mortality rates. It's been involved around, the My collaboration has been funded around two things, which has been combining health and combining care, so social care and health care. So it's been looking at telehealth technologies and integrating them into the home to help people monitor their own health. So an example here is measuring the blood glucose. Readings go into a system. A trained professional reviews those readings, and then they're contacted with any suggestions. But that also happens automatically. There's also been technologies to support people becoming more independent. And I don't know if anyone's seen the HFT Smart House. A show of hands, has anyone seen that? Okay, that's great. So we work closely with HFT with things like the big picture phone, bed occupancy sensors, panic alarms, door sensors, and easy-to-use mobile phones. This is where it's based, and I don't know if anyone's seen the recent reports on mortality in the UK, but I think Liverpool is number 3 on the charts and Manchester is number 1 on the charts. Almost like the football, Liverpool's a bit further down in that. So really there is a big issue, and there's extreme difficulties with poverty in Liverpool. You've got 4 generations of unemployed in certain communities, and those are the communities and people who have homes, who are living in their homes. So the aims of the More Independent program, which I'm part of, are increasing demand for better health and impacting upon 50,000 people within that time frame, putting people in control and care of their own health care and social care, improving knowledge, confidence in use of life-enhancing technologies, improving planning for life, and I still really don't like the LEP thing because it doesn't take far to abstract from someone who uses a LEP, but I won't. What would they be called? And then also increasing access to life-enhancing technology. So this is anything that will enhance your life. So it could be a mobile phone, it could be a seasonal affective disorder light, it could be a magic plug that tells you when your sink water is too hot. So really the aims of this, of use cases and quotes from people who want to live in their own home, they want to be more independent, they want to start exercising, they want to see more of their grandchildren. So working out what really matters to people. The More Independent collaboration has been working with big industry, Philips and Tunstall. We're working with the CCG, the Liverpool Primary it says Primary Care Trust. That doesn't exist anymore, as I'm sure many of you are aware. But Liverpool NHS, we're working with Riverside, PSS, or the charity that started Citizens Advice Bureau, and HFT, Learning Disabilities Charity. This is the Smart House put up somewhere else, and if any of you have not seen the Smart House, please go along and have a look. So my life is really, it's a membership scheme with product and service officers. There's information and advice line, which is free. We have community champions. It's people who go out and they volunteer into the community and add more to the community. There's technology retail outlets that's trying to consumerise healthcare, which is something I'm very keen on. It's giving people so they're empowered to take responsibility of their own health. There's also an online virtual smart house. So if you type in virtual smart house into Google, you can go in there and interact with an online virtual smart house, and also carer support. So within this program, and this is a horrible slide, and I've put it up here on purpose, but within the program we decide how we're going to and who we're going to give telehealth or telecare interventions to. So what is the latest and greatest thing is to do a risk stratification, and this is the example of the algorithms that are run through the Welsh model for risk stratification. So you take a whole lot of inputs, and with those inputs you calculate what is the percentage chance of that person being hospitalised in the next 12 months. So you're given a number with that, and based on that number you decide a predetermined telehealth or telecare intervention. And if the person or the population of people that you applied this to do not get admitted at the rate that was predicted, you can all give yourself a pat on the back, which is quite reasonable. However, it's a 12-month target, and here we're looking at all the periods here. There's 2 years, or they're continuous, or they are forever. So the actual period that you're actually analysing and assessing is much longer than the actual period that you're looking at. And really, there wasn't really anything to look at short-term reporters. The other thing that was not really determined by these models is how do you decide what are the best interventions and what is the one best intervention, what the best combination of interventions. What are the interventions? And I would argue that interventions are not just about a telehealth or telecare service or device. It's also about things like people coming around, neighbours visiting. It's about community champions coming along. And the other question is, can you use analytics over time to learn what the best choices might actually be? So this is where the first name of Lincus, which was adaptive optimization methodology, was born. And obviously that's a mouthful. That changed into the My Intervention Support Tool, or MIST, which is now Lincus. But basically it looked at inputs, interventions and outputs. And over time, with enough data, can mathematically determine what the best intervention for that person might be, or that population of people. There is a long way to go before we get there, though. There's a few other questions that needed to be asked. I've already pointed out that the risk stratification model, which we're initially going to use, doesn't really focus on short-term benefit. So when you look at short-term benefit, you need to look at data that you can collect rapidly. So if we look at on-body devices, that's very rapid. That can be several times a second. If we look at questionnaires, that can also be reasonably rapid. It can be daily or 2 or 3 times daily. Or more complex questionnaires, we can look at 3 monthly. So the next question was, what actually are those early reporters? What are the ones that are easy to get? And then the third question on this section is, what really matters to stakeholders? And with that question is, who are the stakeholders? So generally when we're looking at that model, the stakeholders are commissioners and people who might be involved in procurement. But there are many more stakeholders. There's the individual themselves. What really matters to them? And you can ask them on a daily basis. Things will change on a daily basis. What really matters to the family? What really matters to the neighbours? What matters to the health-care centre? What matters to the emergency service? So there's multiple different stakeholders. So we start breaking things down to 3 overall categories of, okay, there's the financial side of social and health care, which is the one that's typically focused on. There's the individual side of social and health care, which there is some focus, but it's generally not the major focus for the decision making. And then there's a final one, which is a community metric, or the community that actually supports that person, what really matters to them. So how do we develop the right questions? We actually go out and ask them. We give limits, but we go out and ask the people. We can base things off validated questionnaires, but ideally we go out and ask. So finally, how do we, on this section, how do we minimise survey burden? So how do we actually decrease the burden of a survey and make them also inclusive? So we've been developing a system which is based in one of Rescon's technologies, is a system based on communication to the medical record using pictures, so using pictorial representation of symptoms, and using a linear analogue scale, which was developed in people who are trying to monitor chronic pain and get good, dependable and robust results, measuring them over time. So we took that symptom tracker technology and applied that to this problem set within the My collaboration. One question that comes up, how do we combat cheating or fraud? How does this potentially replace an interview with a healthcare worker? And really, none of this does actually replace any interview with a healthcare worker. And it doesn't matter who you're talking to or what way that people are talking. They're still going to be cheating and they're still going to be fraudulent because they have potentially have other interests at heart. Over time, though, with analytics, you can look at patterns that are associated with someone who may be cheating the system, or someone who may have other intentions, or are not quite addressing things such as chronic pain. I mean, pain that's 10 out of 10 all the time, you will find that with a numerical score, people will tend to stick to the number. My pain's always 10 out of 10. However, if they have a sliding analogue scale, they might go to maximum, but you say, was it better or worse yesterday? And they say, well, maybe it was a little bit better than yesterday, so you go one down. And that will count for number 9, though they won't have to fix on number 9 in their head. I find this especially because I track my health, and I find this especially true for motivation. So most days I'm motivation number 10, but some days I'm number 9 or number 8, and that does really depend. I definitely bounce out of bed every morning to do my work, though. Finally, also in here, we're looking at how do we combine the data. So how do we combine all this data? So at the moment, we're simply going for fusion of all the different data sets, and I can show you some slides in a second with the Liverpool homeless population project. And then how do we visualise the data? Well, the data is visualised in the way that the stakeholder wants to see it. So there's many different ways of visualising the data, and we have visualisation experts on our team to show the data in different ways. And we're not really locked down to anything. You can visualise the data using sounds, using movies, using line graphs, or using pie charts, and whatever people are best and happiest with. So this is an example of some of the work now we're doing with the Liverpool project. So this is an example of the police. So it's how many resources are spent on dealing with the homeless population. This hasn't come out too well, but we've got the questions here of holding cell occupancy, and this is a slider, community outreach, patrolling officers, station officers, paperwork, and anything else. So really, it's these questions have actually been defined by the police station. The stakeholders themselves say, what are the 5 to 10 markers that show that where the homeless population really have an impact on your business? And I've used police here because I assume there's probably no police in the room. But it shows you that it really can be applied to many different categories. So here is a sample, an example of some wellbeing tracker that was actually developed not with this project, but this was developed for the human performance market or the sports market, where you've got all these symptoms and signs of overtraining in athletes, and you can see these actually apply to the health of everyone. So using icons to show sleeping well or poorly, having a cough, upper respiratory tract infection, so you can't see that very well, but it's got a red nose and a red throat, injury and muscle pain. There is also the capability of taking a photo. Now that's especially true on this application for the homeless population, where you might want to take a photo of where they've slept, a rash, skin conditions or problems, track marks, and it also does a GPS upload so you can know exactly where you've taken that data and that changes. This is especially relevant for my data because I travel so much, so I might be at Heathrow in the morning and at Washington Dulles in the afternoon, and then maybe down somewhere else, and that does impact definitely on sleep, and it definitely impacts on upper respiratory tract infection and quite often muscle pain. So we also can monitor things such as meal, for instance, alcohol, and then that goes to a different screen which looks at quality and quantity, so monitoring those sorts of things. Finally, going into overall well-being for the homeless population, some of the data that we've seen. So this is tracking over time. So here we have the 5 categories: drugs, solvents, alcohol, general health, housing and homelessness, mental health and offending. And you can track them over time. If you click one of these, you break it down, and then you can break it down into individuals that you may be looking at. This is fused data from several individuals. So here we have a look at retail sentiment. Now this is made up data here, but we have a look at overall retail sentiment broken down into Morrison's, Rescon and Tesco. So you can see the retail giant Rescon has had a dip here, and then overall sentiment for all sectors combined, and this is looking at health centres, police, and also retail combined. So here we have, if you want to break down on it, so if you wanted to look at Rescon within there, you can break down further and have a look at income, security, in-shop atmosphere, customers, property and business. Again, talking with the local retail association, those are the things that matter to them. So the stakeholder-led approach. So where are we now with this project? We're working with the Liverpool City Council, Plus Dane, YMCA and other in this big lottery-funded project to look at interventions on the homeless population to further develop the questions, to make them robust, to make them in alliance with the validated questionnaires that are out there. We've also linked with PSS, which is the person-centred solutions charity, and we're also working with Inclusion for All, which is a charitable organisation that looks after veterans and servicemen and their families. So looking at the impact of going to war and coming back from war on servicemen and their families. And all of these are within the Liverpool region. So where's Rescon now? Well, we're continuing to develop the user interfaces, visualisation, analytics, and we're hardening our security. So we've brought in security experts to look after this protected personalised data. And we're also continuing to talk to other people about further collaborations that we can work on to develop this tool as a impact tool, not only for looking at the homeless, not only for looking at war fighters and veterans, and not only, well, the PSS one is on childhood obesity, but also looking at issues such as long-term conditions and monitoring that over time. So I think I've finished early. It's just getting on amber there. So we're at stand number 34. So this is the link for the Lincus site. So just a little bit about Lincus. It came out of adaptive optimization methodology, which came out of the My Intervention Support tool. Now Lincus came because we were developed in Liverpool. Incussus is the Latin word for impact, and Lincus is really what it's doing. It's linking individuals with their communities. So this is Rescon's website, and also encourage you to visit the HFT Smart House. It's very difficult to miss. It's just on the left outside the room there. So have you got any questions? Oh, sorry,
Very much,
I'll let you do
Tom.
that.
Yes, we've got time for a few questions. I suppose just while people are thinking of their questions, how many of you have actually been involved with the Dallas initiative, which was a massive initiative funded by BIS, I think, wasn't it?
Technology Strategy Board.
Yeah, Technology Strategy Board. Because actually we sort of learnt about it a little later on, but it was a massive piece of work, and this is the rollout, and it's got several brothers and sisters, hasn't it, around the country, trying out different elements of what the learning from the Dallas project has been. And I'm hoping at some stage there'll be a very accessible report into Dallas as a whole, which will help us or people who aren't up to speed yet with kind of what else is coming out of it.
Certainly.
One of the things that we find in home care or personal services particularly is an element of concern that the more technology is used, the less personal contact will be valued. And I think some of the things you've said and you've shown should be quite reassuring, which is like this does not replace person-to-person interaction. But I think that has been one of the things that's made the home care sector particularly a little bit cautious about some of these new ideas. I don't know whether I'm kind of touching on sore spots here, but I've been struck with how little people actually want to espouse technology when it's very obvious that technology has a major part to play in what we're trying to achieve. But what it mustn't do is replace the person-to-person contact. I don't know whether you've got any comments to make about that.
No, I completely agree, and I'm dismayed at the fact that people can be Facebooking across the world, but they won't talk to people in their own house. They won't talk to their own neighbours. I think technology is there, and one of the other, and I see a few smiles in the room, so there's some obviously personal things which I've also had, but there's the other thing, which is the getting hold of information that's valid and validated information. That's a real problem, again, that we're getting with technology anyway, because people are out there and they're doing a search on, for instance, sports nutrition and coming out with something. But if you can actually provide validated sites where you can trust that information, I think there needs to be more signposting. Say, hey, I actually recognise this site because it's been it's been given a kite mark or an endorsement by agencies that I actually trust. They're saying this is actually good information, and I think there needs to be a lot more of that out there, a little bit like the the Amazon sort of standard where you give a rating of 5 stars and you can trust a product. I think that needs to be there for information, and it also needs to be there for services, and I think we can really do something there that's quite positive. And another thing with this tool we're developing here, it's in keeping with a lot of other tools we're developing, but it's by no means meant to replace the person-to-person contact. Hopefully it makes the person-to-person contact more personable and less about taking metrics, because you can already take a lot of metrics and recording away from the surgery or away from those actual person-to-person interventions. You can actually take your time to go, how are you going? How's it feeling? Have a look at them in the eyes rather than going, okay, I'm going to take your blood pressure now we need to do an ECG. It will get rid of all those artificial mechanics that actually take away from the human interaction. I think we can do a lot more about really amplifying the human interaction when it happens with this sort of technology.